Good morning, Dr. Charles, Dr. Georgina, Dr. Kapshana, Dr. Camille, and everyone that is here, especially to Stephanie for that heart-wrenching story. You know, one of the things before I go in that I always say to the folks, never let me speak after the valedictorian and before lunch. Because one, if it's a valedictorian, they're so eloquent and no one's listening to me, and if it's for lunch, everyone's stomach is growling and they don't hear me anyway. I now have to say, do not let me speak after Stephanie Barnes, because I'm not quite sure how to handle that. But it's really an honor for me to be here and a chance to say a couple of words of introduction. Before I make my remarks, if you bear with me on a poem that I really got introduced to a while back when I brought Stephanie on board as our ADA coordinator, and I began to understand the need for the Virgin Islands to have something that had been lost for a long time that we had not put in place. And it's a poem that's I Am Autism. Allow me to introduce myself to you. My name is Autism. Perhaps you know me or know of me. I am a condition, disorder that affects many people. I strike at will, when and where I want. Unlike Down syndromes or birth defects, I leave no marks on those I strike. In fact, I pride myself on the ability to infiltrate a child's life while leaving him or her strikingly handsome. Many people do not even know I am there. They blame the child for what I cause him or her to do. I strike boys and girls, infants and toddlers. I find my best victims to be boys around the age of 2, but any child will do. I strike rich and poor alike. The rich combat me with education and therapy. The poor shut their children away and cannot afford to fight me. I'm able to win in the lives of poor children more than those of the wealthy. I'm an equal opportunity disorder. I strike whites and blacks, Mexicans, Ukrainians, Slavs, Japanese, and Koreans. I know no geographical bounds. I am strong, and I'm getting stronger. Every year, every month, every day, every second, every minute. I am concerned that money might be allotted to combat me and take over children, but so far, I have little fear. When I come to stay. I take the dreams and the hopes of families and trample them with delight. I see fear and confusion in the eyes of my victims and see the formation of wrinkles and the worries and the pain on the face of their parents. I take it away and I give nothing but bewilderment and loathing. I take speech and learning, I take socialization and understanding. What I leave behind is almost worse than death. I fear nothing except courage, which I thankfully see little of. I fear those who take a stand against me and attempt to fight me and bring others into that fight as well. I'm looking for new children to consume and new lives to destroy. I dread the day I will be looked upon with pity or worse yet, understanding. For that day is the day I will begin to die. I'm safe. I'm free to prowl onward, free to cause the pain and suffering that I do well. And I'm on a mission to have much more and to do. Thankfully, no one will be stopping me yet. And I read that because to me it sets in perspective this conference today. Because you are the force that is going to destroy the ignorance, the inability to understand something that for so long we have not been able to understand. One of the things that Cecile and I wanted to do when I became governor, one of the reasons I ran for governor in 2006, quite frankly, is because I believe in our children more than anything. I established the Children and Families Council and made it chair. I put Stephanie as the ADA coordinator. We've started early childhood education programs at the schools, at Head Start, and also in conjunction with the university. We've tried to get more researchers to special education than we have in the past, and also, at the same time, to understand, most importantly, what we're not doing right and what we need to do more of. I know very well from NPH to Department of Education to MCH that we have to do more to be able to understand what is combating and what our children are going through. When you look at the statistics from 2008 to 2012, you see that the autism category, children ages 3, the number has not changed drastically. But however, up to age 21, it's beginning to increase, and if you look at the numbers with developmentally delayed, You see that his balloon never cracking 100, but clearly an indication that it's a group that we need to pay more attention to. I understand that under affordable health care under President Obama, we need to use those resources to be able to use it towards our children, with the providers, and to have the specialists that are necessary to supplement the work of Dr. Valentine, to supplement the work of pediatrician in St. Croix, to be able that parents have a chance to have someone that is an advocate and understands what they're going through. I compliment all of you for coming to the 6th annual conference because of your interest, but more so because of your advocacy. It is easy on many occasions to deal with the easy things that are going on, to deal with the children that get A's and not deal with the young folks that are dropping out. It is easy to deal with those that do not have the challenges that others have. But the understanding of policy and politics and our responsibility is to not deal with the easy things, to not deal with those who clearly have advantages that others don't, but to help those that have challenges understand that we understand what they're going through and the sacrifices that we have to make. It doesn't matter whether we have a deficit or we have problems. We have a responsibility. And that responsibility is to make sure that for the youngest of our children, we give them a chance. And for those that are a little bit of a disadvantage, help them to come forward. I read that poem because I know that those that are participating from the private sector to the government agencies, you're in a fight. You're in a fight that many times you don't think that those above you understand or allocate the resources to do the job or give you the time to train. I can tell you that through the Office of Special Education, through MCH, through infants and toddlers, we are going to try to change that. Even with the other challenges that we have, I understand that this is something that we must and we will make a priority. So on behalf of my entire administration, on behalf of those that are here to learn and those that are here to do, thank you for taking the time and thank you for letting me address you. Have a good day.
Thank you very much, Governor. The governor talks all the time. He's a good speaker. And one of the things I learned as a speaker a long time ago, just beware when somebody gets up and says, don't put me behind a valedictorian, a child, or an animal, because they will really wear you out. I've been in situations like that before. But the governor knows what he's talking about. I pulled him up this morning in case I needed to make a formal introduction. So we know a lot about the governor, where he's born, where he went to school, and those kinds of things. But I do know also that he's a very busy man. We just thank you from the bottom of our collective heart for taking the time to come out and share those words of wisdom with us this morning. The Virgin Islands University Center for Excellence in Developmental Disabilities was founded about 19 or 20 years ago now by Dr. David Autism, an affiliate of the university. And our mission is to provide support and tools to individuals with developmental disabilities so that they can live happy, productive, and inclusive lives just like everybody else. People with disabilities have the right to live, learn, love, go to movies, use a bathroom in public places, and they can't all because we discriminate against folks with disabilities. And our job is to make sure that that ceases to the extent that we can. Autism is a complex and interesting concept to think about. It confuses people. And one way to eliminate that confusion and figure out ways to deal with it is to host conferences like this and to bring in people like the folks I'm going to introduce in a moment. So we're just happy to have you here. When you get to be my age, you'll understand it. Our keynote presenter is, well, before I do that, let me take a minute to introduce some, I don't see any of our staff people, but Andrea Plunkett is our program coordinator. She's probably out in the hall, who's here to help you. Kareem in the back, our IT person, raise your hand. Kareem, he's the one who's live streaming you. Dr. Carl Cole is around someplace, Ray Ford is around someplace, and these folks are invaluable to us in terms of the work that they do to help me and Dr. Hopkins make sure that everything does what it's supposed to do at the DI you said. That having been said, Dr. Georgiana Peacock, our keynote speaker, you are a medical officer and developmental behavioral pediatrician with the Prevention Research Branch in the Centers for Disease Control and Prevention's National Center for Birth Defects and developmental disabilities. Mouthful. You are currently on detail working with CDC's Office of Public Health Preparedness and Response on an initiative to enhance public health disaster preparedness and response for children. You received your Doctor of Medicine and Master in Public Health from the University of Kansas. You are also a former Leadership, Education, and Neurodevelopmental and Related Disability, or LEND, trainee. You completed your Developmental Behavioral Pediatric Fellowship at Developmental Disabilities Center at the University of Kansas Medical Center. You initially joined CDC as an Association for Universities Centers on Disabilities, AUCD Fellow. You and your wonderfully supportive husband have 4 children, which gives me another reason to let you know how grateful we are that you took the time from your busy schedule to be with us. And it's my privilege to let all of our attendees know that both you and Dr. Providence, did I get that right? I said it right. Are here at no charge to be our youth students. Especially in these financial times. So that's a formal introduction to our keynote speaker, Dr. Peacock. But before she comes up, I would like both of our presenters to stand. Dr. Shana Krollich is also with us, and I'll introduce her. You can read her bio later on, and I'll do a more formal introduction later on. If you would both stand up so our folks can see who you are. And now, keynote speaker, Dr. Peacock.
While we're getting started, can everyone hear me? No? Yes? Okay. All right. So I think we've got to restart the computers, so we will do that. But in the meantime, I just wanted to thank, I'm a little short of words now, having heard all of the introductions this morning. And I think that's why we're here today. We're here today because we're here for the families and for the children. And so what I'm hoping to do is to share with you some tools that help to identify more children early, and talk about the services and supports that children need through the lifespan, and those families that need those supports as well, to care for children with autism that grow up to adults with autism, so that they can be happy, supported, and included in our community. And so, I think you gave us just really the right words to put this in the right perspective. I'm going to be talking over this next hour about a lot of things. I'm going to go through things quite rapidly. I'm going to cover a lot of different topics, and the reason for that is because then Dr. Kralovic and I are going to be talking about these things in more details as we go into the breakout sessions. So I'm sort of throwing a lot of information at you, and hopefully sort of whetting your appetite so that we're talking all the way about early identification through screening and diagnosis, and treatment and care for children with autism. And I think we're ready to go. So, so I just really sort of covered that. So we're going to go through defining what autism is, thinking about who are at higher risk for autism, the important need to identify these children as soon as we can, because we know that we can make a difference. And our job, as many of you introduced yourselves, you work in the schools, you work in public health, you work in the medical clinics, your family members, you know that the earlier that you can get support and start having that hope, I think the better it is for families and the better it is for the community. I'm going to talk a little bit about some of the scientific advances, and then we'll talk about the plans for the rest of the week. So we've heard some stories about children with autism. I'm going to talk about a few more children with autism to start this talk today. So this is Jacob and Tyler, and they're 24-month twins, but they seem to be following different developmental paths. So Jacob says simple things like uh-oh when he was 1 year old, and now at 2 years old, he's putting words together to ask what he wants. He says things like eat a cookie, he points to the cookie that he wants to eat. He loves being with other children, and he loves to play make-believe, and he pretends to call grandma on the phone. So these are all milestones that we're looking at that we think are pretty typical for a 2-year-old. And the language is there, that social interaction is there. His brother, however, Tyler, doesn't use words to tell you what he wants. He has a favorite toy that he plays with a lot, and he can't make words, so he can sing, but he sings one song over and over again, and he's able to say those words, but he seems to not be actually responding in conversation. He doesn't often make eye contact, but sometimes there's some fleeting connection, and he doesn't seem to have interest in playing with other children. So what we're talking about here is two twins who were in the same environment, in that same family, but they're acting very differently. And Tyler's giving us a lot of these red flags that have been showing up over the last year. And he indeed needs some more evaluation and needs to see if he has autism or if he has some of those warning signs. So now I'm going to play you a video that is not these twins, but it's two twins who are 19 months old. And I want you to just watch the video. We may talk a little bit, I may ask you for a couple of first impressions of this video, but then we may go into more detail in our breakout session. I'm going to start the video playing, but we're looking for a cord to plug up our computer. So if it goes out, we'll get it back online.
That's right. Here it is. Uh-oh. No! Push. Good boy. Ready, set. No! You can push. Hold on, stay there. Go. Stop. Stay up here, please. Good boy. Reset. Go. Good push. Here, go.
So let's take just a couple minutes now, and I'd like someone just to sort of raise their hand and tell me what was something different that you saw in those two different points. Sorry? Or shout it out. That's fine.
Lack of reciprocation.
So
Back and forth.
So in our second twin, a lack of reciprocation. So the second twin was not getting into that game of playing with the twin. Or what else did we see? Sorry? Interaction. So less interaction.
Language.
Pardon?
Language.
Language. The differences in language.
Eye contact.
Differences in eye contact. So can we diagnose autism from a 30-second video? Absolutely not. But what I want to show you is that we can see differences in these toddlers very, very young. So we can see differences, again, with twins. So they've grown up sort of in the same environment. They've had the same types of education, the same kind of stimulation. They're developing differently. And so the purpose of this video is to sort of demonstrate some of those, what we would call red flags. And we're going to talk about red flags a little bit more, mostly in our breakout sessions. We'll just get back to where I was. But let me back up just a little bit and talk about sort of what we think of as autism and sort of some of the history of autism, some of the core features of autism. So autism was first described in 1943 by a psychiatrist, Leo Kanner. Right around the same time, Hans Asperger was also describing what he called autistic psychopathology. And his research was on sort of a slightly different group of children, boys, with autism, who later coined the term Asperger's syndrome from the work that he had done. So that was in the 1980s was when Asperger's was really talked about more. And autism, as we've heard from our speakers before me, was once seen as a rare condition. But we know now that I think, what we heard earlier is, what we have been doing is diagnosing more. Autism is a developmental disability. It's not recognizable at birth. We know that it's a lifelong disability, but that doesn't mean that children aren't going to be productive, they're not going to be happy, they're not going to be part of our community as they grow up if we give them the supports and the resources they need to follow that trajectory. It's a complex disorder, so there's a lot of different areas that are affected. We hear concerns about behavior, we've got concerns about speech and language, we've got medical concerns, there's lots of different areas that are affected. And there's a wide range of impairments. So even when we think about the early researchers, Dr. Kanner and Dr. Asperger, who looked at some of those initially described autism, they described a variety of functioning in the people that had autism. So when we talk about the prevalence, we certainly have seen what we see as a rise in prevalence. And so I work with many colleagues at the CDC who this is what they do. They work on the prevalence studies, and what they do is they have a number of sites throughout the United States who look at medical records, who look at school records, and they try to determine the number of children who have autism in those sites, and then they come up with an average by averaging those sites. The number of sites has changed over time. Most recently, there's been 8 sites that they looked at, and the most recent number that was published was 1 in 88, which is about 1% of children. They look at 8-year-olds, and the reason they look at 8-year-olds in this data that they're looking at is because they think that most children in the settings where they're looking have been diagnosed with autism by 8 years old, so that they're hoping that they're catching most of the children in that area. But as I'll go into a little more detail in this study later when I'm talking about the scientific advances, you'll see there's a huge disparity between different groups and different ethnic groups. So what is that telling us? It's telling us that there's probably not a difference in different ethnic groups having different amounts of autism, but a difference in identification. And that we know in this 1%, or 1 in 88, so about 1%, about half of the people that are diagnosed with autism also have a co-occurring intellectual disability. Because this is a behavioral diagnosis, the way we come up with the prevalence numbers right now is by people looking at these records, and then a clinician who's familiar with autism reviews every description of that child. it makes it challenging because it means that you're having to look at the records that you have. So it's whatever people have written in medical records and written in educational records that determine you coming to that prevalence number. So, but what I think it does do is it gives us a guide, and like we heard before from Dr. McHale, you know, the prevalence number only matters to tell us that we've got a lot of children and a lot of families affected by autism that we need to be caring more for. So I think, you know, I do come from the CDC and there's a lot of focus on numbers, but what I really think is that we need to be focusing on every child that has autism and every family member that is working and caring for a child with autism. So what are those core features? What are they looking for when they're looking in those records? What is a pediatrician looking for when they're trying to help identify a child at risk? They're looking for problems with communication. They're looking for problems with social interaction. And they're looking for limited or repetitive patterns of behavior or unusual interests. And so it's these three things that are being looked for to make a behavioral diagnosis of autism. We hear, however, there's a lot of things that people say about children with autism that I think really are myths. We hear that children with, you know, a parent might say to me, well, my child doesn't have autism because he's affectionate with me, he loves me, he gives me hugs. It's just one of the myths that children with autism don't connect with the people around them. They do, they just have difficulty with those connections. And different children with autism will connect differently with the family members that they have. So these are some of the myths, that they don't make attachments. Certainly, I am sure that, well, we heard from your story, you know, about your son calling and saying, I'm going to miss the autism conference this year. You know, I think he's thinking of all those people that come to the autism conference. He's understanding, he's got a community around him that's supporting him. And that certainly has made a connection with him. And I you know, I don't want to put words in his mouth, but that's sort of what I feel from you when you're talking about him saying, I don't think he's missing the actual conference room. I think he's missing those people, you know. That they never make eye contact. Difficulty making eye contact often, but certainly children with autism have eye contact. And one of those things that we do with children when we're trying to work with them when they're really young is really working on that eye contact, because we learn so much from others by looking at people in their eyes. And so and children with autism often don't sort of intuitively do that. And so we need to help them to do that, because you miss a lot if you're not focusing on the eyes of others, if you're not sort of looking at them. But they don't communicate. Certainly, children with autism communicate. Sometimes, especially when they're really young and we're making those early diagnoses, they're communicating, but maybe not in really effective ways. Maybe the only way they can communicate is by screaming or yelling, and they're saying, I'm frustrated, I can't tell you what I want. So if we can take that frustration and turn that into a way for them to more appropriately or communicate or get what they it's very hard if you're just screaming to be able to exactly understand what that child wants. So if we can give children signs, if we can give children pictures, if we can give children other ways as we're working on that language coming in, we give that child, we lower that level of frustration. Another myth maybe that a child engages in self-stimulatory or really repetitive behaviors all the time. We certainly see that children and adults with autism have repetitive behaviors. Certainly don't do them all the time. And a lack of emotional experience, which I think I've already covered. We also know, and when I was talking about autism being a very complex disorder, that there are other things associated with autism spectrum disorders. There's often problems with attention or activity, attention and activity problems. There's often, there can be unusual skills or uneven skills. That could be a problem. That can be something that's really great. You can be a great musician. You can be a great artist. You can be really good at math. none of these things are sort of assigned to that diagnosis of autism, but what this really is speaking to is that we see sort of an uneven profile. We see that children and adults with autism have some things that they can do really well and have some things that they really have challenges with. I don't actually think that that's necessarily unlike most of us in the world. Most of us in the world have talents and gifts. All of us in the world have talents and gifts. I think that maybe we just see that to more extremes sometimes in children and adults with autism. Unusual sensory responses. So we may talk and see children who have a really hard time eating different foods. And they can get much more selective over time. And that's, on one hand, if you're getting the nutrition you need and you're getting the foods you need, it probably doesn't matter that you're only eating a couple different things. But if you're so selective because of the textures and the things like that associated with the foods, then that can be a problem. And so I think I'm not giving you sort of concrete answers of this is a description of someone that has autism and this is a description of someone who doesn't, because it's really getting to know that individual child. And I think many people in the autism advocacy world have talked about how every individual with autism is an individual with autism, and they have their own unique characteristics, and they have also a lot in common with all of us. And so, but these are things that we look for as associated features with autism. A lot of sleeping problems or sleeping issues, a lot of eating issues, as I talked before. Sometimes aggression or self-injurious behavior. Often that's because it's being used as a form of communication. And so we got to figure out what this child is trying to communicate and give him or her a better way to communicate so he doesn't hurt others or hurt himself. And changes in mood. So like we said on a previous slide, there is difference in emotional response. And some children, especially those that are higher or what we sort of call higher functioning or more functional on the autism spectrum, can notice that they are different and can notice that they have a hard time sort of making and engaging in friendships, and that can be really sad and really depressing, and really we have to, especially as healthcare providers and I think service providers and educators who care for some of the higher functioning individuals with autism, is look for these mood changes. Because I think it's another thing that is a quality of life thing. It's really hard to feel like a productive member of your society when you're always feeling just like you're not quite part of the group. And so looking for those mood and affect. So switching gears a little bit and talking about causes. So causes, and I actually, even though I have it on my slide, I like to sort of talk about risk factors, because I think that what we're going to find is just like, what we are finding is just like when we talk about someone who has heart disease and people who are at risk for having a heart attack. We can't look at someone and say, you're going to have a heart attack and you're not going to have a heart attack. We can say, these are the things that make you more likely to have a heart attack, high blood pressure, high cholesterol, being maybe overweight, things like that, than another person. And I think what we're going to end up having as we look at the advances in science related to autism is there are going to be things that point towards a child being at higher risk for developing symptoms of autism versus another. What that means is let's pay attention, to these kids that are at higher risk and make sure they're in good preschool programs and they're getting good language stimulation, and we're also looking for the red flags. These red flags of having difficulty communicating, difficulty with social interaction, so that we can really address those early on. We do know that the earlier you start addressing things, the easier it is to get children on that trajectory that we would like them to be on. So, like it says here, it's likely that there's multiple causes or multiple risk factors, and likely as we learn more about autism and we learn more about the genetic basis, where we will be able to better define that this child has sort of this type of autism and this child has this type of autism, and not only that, but the therapies and the interventions we use for one child versus another may work better in one child than another, and so that we really need to tailor what we're doing to help that child with autism. And if something's not going well, if a child is not improving, thinking about, well, is it our strategy, is it our teaching, is it our therapies that we're using that are not working, and we need to take a different approach. We certainly believe, and I think most people in the autism world believe that there's a biologic component to this, there's a genetic component to autism, and there's something that you're sort of predisposed to autism, and then there's something that happens, whether this is before a child's born, early on, that makes that child develop autism versus a child not. We know that two twins can develop autism. If you're identical twins, is a 95% chance that if one identical twin has autism, that the other one will have autism. However, it's not 100%. So what is that difference? Where, so there is a genetic influence, but there's something else. And so this is sort of a first attempt or an early attempt to thinking about who is at higher risk for developing autism. The reason is not to then point to a child and say, gosh, you're going to have autism, and I know you're going to have it, and that's too bad. It's so that we can identify those kids at higher risk so we can make sure we're paying attention. That's the whole thing we're trying to do with early identification, is say, let's pay attention, especially to these kids who are at higher risk. So if you have a sibling with an autism spectrum disorder, you're more likely. One of the latest studies showed that if you have, if there's a child with autism, there's about a 18 to 20% chance that you would have subsequent children with autism. If you have two children with autism, that goes up much higher. We know that males are more likely to have autism than females in a ratio of about 4 to 1. Older parents are more likely to have children with autism. And I'll talk in a little bit about some of the genetics that they're looking at that maybe explain some of that. Premature birth has been associated with a higher rate of autism and also low birth weight. A family history of autoimmune disorders, a family history of psychiatric disorders or conditions. And then we also know certain genetic syndromes that we have well defined, like Down syndrome or Fragile X. The children with Fragile X, about a third of children with Fragile X will also have autism. About 10% of children with Down syndrome will also have autism. So it's higher in those disorders, but it doesn't mean because you have Fragile X you're going to have autism, because you have Down syndrome you're going to have autism. These are all just risk factors. These are things on that list that make you more likely to have autism. So you'll see in your packets that we included a few materials from that the CDC has been working on. My introduction talked about the work I'm currently doing, which is working on really taking care of children in disaster preparedness planning and response. However, what I did when I first came to CDC and over the last 5 years or so has been working on the Learn the Signs Act Early campaign, which is a campaign to help identify children with autism earlier. You'll see in your packet a milestone moments booklet, and so this is something that we put together about a year ago. And what this is these are milestones that children should reach at different ages. And then it also gives you things that you can do with your child, sort of on the opposite page. And then for each age, it also gives you things that you should watch for at that particular age. And talk to your doctor, talk to your early intervention providers, talk to your teachers, your child's teacher, if your child isn't doing those things. What the materials with the Learn the Signs Act Early campaign are supposed to do is help parents identify concerns with milestones. It's not a way to diagnose autism. It's a way to raise those red flags. It's to say, my child isn't doing the things I would expect at a certain age. Can you help me try to figure out what's going on? We also, what we're going to be using in the breakout sessions is we're going to be using an autism curriculum that has been developed for healthcare providers and also other professionals and community members to really go through a lot of the details that I'm touching on right now. And so there's an autism curriculum that can be either used in a teaching format, or you can go through all the modules on your own online. And so there's 7 different modules that you can go through, and it will take you through all of these different pieces of going from early identification all the way through treatment. Really what we're trying to do at CDC is we're trying to help support you all who are doing the important work of identifying children with autism and helping parents get their children to the place they need to be as soon as possible. What I can tell you is in the developmental clinic that I do a couple times a month, I do see those numbers coming down. And so, I hope that through bringing people in like what I'm doing and the good work that all of you are out there doing, is that children will be diagnosed earlier in the Virgin Islands, because it just means they have more chance at that early intervention and that better jump start to really getting ready to doing as well as they can in school and as they grow into adulthood. And why do we push this early intervention? Because we know that it can greatly improve a child's development. I'll share some of the scientific advances in a minute, but we can actually see changes in the way the brain is developing if we get that early intervention in there. There's different categories of intervention. I think, first and foremost, it's behavioral and educational interventions. That's the foundation for any program for a child with autism. Has to be, let's address the behaviors, because the behaviors a lot of times can get in the way of learning. So whether it's a repetitive behavior that a child is doing, getting in the way, or if it's more of an aggression or being so upset that they can't communicate and frustrated that they can't focus on learning. And so what we often do first is really focus on those behaviors with children so that we can get them ready to learn. There's different ways to do that. I've got a few listed there. We know that there are medical and health concerns. I talked earlier about sleeping and eating issues, toileting issues. That's what I spend probably the most of the time in my clinic if I'm not doing diagnosis, is we're talking about sleep. Because sleep is so important. It's important for everyone in that house. If a child with autism isn't sleeping, it usually means the mom's not sleeping, the dad's not sleeping, the siblings aren't sleeping, the dog's not sleeping, nobody's sleeping. And it's amazing if you can figure out a way for a child. So some children with autism don't sleep as much as other people, and you can't actually really make a child sleep. I mean, you can use, sometimes medications are used to help children sleep longer or to fall asleep. But what you need to do, or what we can work with families to do, is find out which aspect of sleep is the most important. Is it that the child is waking up in the middle of the night and you're worried about their safety? Because there are things we can do to make sure that a child can't get out of the house and things like that. Or is it that they're making a lot of noise and so they're waking everybody up? And so are there things that we can do to address that? Those are just examples of some of the sort of health concerns that can really also impact quality of life and things that we would address from a medical or a health perspective. And then, of course, family and community supports. I think the other thing that is so important when we do early intervention is the early intervention programs make sure that those parents are being taken care of, or should make sure those parents are being taken care of. it's hard. It's hard to take care of a little guy who doesn't know how to communicate very well with you. And so finding other parents who have been through that, that's usually the only instruction I give to a family after I give the diagnosis is, the first thing I want you to do is go find an advocacy group, go find a family, go find somebody you can talk to who's done this and is a couple years ahead of you. And then we'll talk about setting up the things to help with behavior and to help with all education and things like that. But first, find an ally. Find someone you can talk to who can help you not feel alone, because that's when that hope starts growing again. We do know that there are things in educational interventions that are important components to make that intervention successful. I think goes without saying that getting children into intervention soon after autism is expected. You don't need an autism diagnosis to start doing therapies. If you're having trouble with communication, working with a speech-language pathologist, for example, on some of those things to help a child communicate should happen right away as soon as you're seeing delays in language, even if you're waiting maybe for that official diagnosis to come. Engaging the child sort of in an intensive daily instructional program. Some of that is done formally in schools, and sometimes it's done through home programs where therapists are coming to the home, but it's also the parents, getting on the internet and figuring out how am I going to help my child deal with some of the issues that he's having. So it's really that whole team of educators and behavioral therapists and all the allied health professionals and the doctors and the family working together to create that environment where that child starts to learn and the behaviors become minimized. We know, obviously, if you get lower child-to-teacher ratios, that is important because you're giving more attention to that child and giving more individualized care. There are people looking right now to see, what ratios can we do where it's sort of affordable for society as well. It's very difficult to do one-on-one therapy and be able to pay for every child with autism that needs that. So are there other models? And I think, one that we'll talk about in a little bit, the early Start Denver model, is a model that has shown that it doesn't all need to be one-on-one, but it just needs to be highly structured and it needs to be very purposeful. And then promoting being with typical peers. We heard the importance of inclusion, and obviously, I often work with families and they say, my child with autism seems to learn so much from his sibling. It's amazing what good teachers siblings can sometimes be. So I am now going to give you a whirlwind tour of what the Interagency Autism Coordinating Council said were the top 20 advances last year in autism, the top 20 scientific advances. So I am going to go quickly, and I'm not going to give a lot of details, but what I want you to see, really, to take a couple things from this. See the breadth of things that are being done in autism, the amount of research that is being done. I was really blown away as I was reading this summary about all the different aspects of autism research that are going on, and I think we are moving in that direction of better understanding the risk factors, but also these advances talk about the importance for looking at that lifelong approach and looking at what are we doing for adults on the spectrum. And so this is going to be quick, but I'm going to go through these. But what I want you to know is that you can actually go to the Interagency Autism Coordinating Council, which is a council run through the Department of Health and Human Services, and it has representation from each agency in the so the CDC has a representation, and the Maternal Child Health Bureau has representation, and the National Institutes of Health. They're all represented on this council, and what they did is they reached back, as well as advocacy groups. The Geraldine Dawson from Autism Speaks is on there as an example. And they reached back to their organizations and their agencies and their researchers and said, what do you think are the most important advances that happened last year? And they do this every year. So I'd urge you to look at this every year because it's amazing to see the breadth of what has been discovered. And so now we're going to do sort of the 1 to 20, and we're going to do it fairly quickly. What they did was they grouped these articles according to the questions. They have 7 different questions that they want, that they have said in their strategic plan that the research should be answering. And so you'll see when I start doing these on the left-hand side, you'll see the questions that they think that this article responds to. So the question of when should I be concerned? What they did is these researchers looked, and I can actually provide these slides, and I can also provide the references, or you can go to their website to find more details if you'd like those. They looked at children from diagnosis to age 14, and what they found was that, and some of these feel intuitive, but I think it's important to document them. If you were less severe, you had less severe symptoms of autism at diagnosis, you improved more rapidly. The repetitive behaviors stayed the same. So if you had a lot of that repetitive behaviors when you were diagnosed, you tended to have a lot when you were 14. But if you didn't have very many, you tended to remain the same. What that's doing is giving us an idea of which things in autism maybe, it's just giving us more information about autism. If you had severe autism but you didn't have intellectual disability, you did better than those children who had intellectual disability. And then white, non-Hispanic children did better, especially if their mothers had a high educational level. Well, what's that telling us? That's telling us about access to services. And so I think that is, hopefully if they do this study, 10 years from now, hopefully we are doing a better job of identifying kids in different ethnic groups earlier and also giving them the services they need, and that this will look different. So what the bottom line is that we need to better understand the biology and the socioeconomics behind different outcomes. Another, looking at when should I be concerned, what this group did is they looked at these huge genetic databases, and this particular database happened to be in people who had Central European descent. But what they were able to do is they were able to look at children with autism and look at the family's genes as well, or parents' genes, and they were able to find specific differences in genetics that were common among different children with autism in this group. They said, and basically what they're saying is that it translates to saying, there is a genetic basis to this, and that this could be looked at in different ethnic groups as well. How can I understand what's happening? So a lot of these are at the level where they're really looking at sort of the genetic code. And so this particular genetic code, they looked at 3 families who had children that had autism, intellectual disability, and epilepsy. And they had found a mutation in a specific gene. And what they found was that, and so then they had mice, and they gave mice this mutation in the gene. And then they were able to feed these mice a certain kind of amino acid, so a certain kind of protein, and they were able to increase neurologic activity. Then they were able, with these families, to give back this dietary supplement, and they were able to show improvement in the family members as well that had this same difference in their gene. And so what this is really early, and this is just 3 families that happen to have a particular genetic difference in their DNA. But what they were able to show is that that I think, when we're talking about how there's going to be different kinds of autism, this particular group of families that have autism, they actually did better with a very specific supplement to the child's diet. Here's another study that really looked at, what they did is they looked at children who had autism and they were diagnosed somewhere between 18 and 24 months, but they had happened to do, or I mean not happened, it was a study, and they had looked at brain structure early on. What they were able to show is that when they took the children who had autism at 18 to 24 months and they looked back, they could then see differences in the child's brain structure on brain imaging that was predictive of autism. So they can't right now look at an MRI and say, oh, I can look at your MRI at 6 months and say that you're going to have autism. But what they were able to show is that because they don't have that specificity, but they were able to show there were differences in the brain, the way the brain looked, particularly in the white matter, and that it then developed differently. So starting at 6 months, it sort of took a different path. And what that tells us is there's things going on in the brain before we actually see those outward symptoms. And I think that is sort of an important thing. You know, my first slide, or one of my first slides, says you can't diagnose this at birth. But maybe we will get to that point as we're able to get more markers, and if we can do that, we can start our interventions earlier. This looked at vocational interventions, and really what it said was there needs to be more research on what vocational interventions are needed and how that can help young adults with autism. They said that the literature out there wasn't very many, so for researchers out there, this is an area that needs a lot of work, is what the IACC said, and so doing more to look at what interventions help to make, to help young adults with autism be more successful in the workplace and in the community. And finally, I'm coming back to the prevalence study and why we have prevalence studies. So the reason that we are counting people with autism is because it's a way for us to look at which groups are being identified, which groups are not being identified. I think it'll be these other researchers that tell us, is it rising, is the prevalence rising for other reasons? But this, when we go into more details on this most recent prevalence study, we did see that the prevalence of autism was highest in that non-Hispanic white group and lowest in Hispanic children. However, the biggest increases in prevalence we saw in Hispanic children and non-Hispanic black children. Therefore, what are we, that definitely, it's that access to care that is one of those contributors to our prevalence numbers. So why did I go through all this? Is because I think it's important to know that there's lots of people out there looking at lots of different aspects of autism, and the goal is really to put these puzzle pieces together. We start with the children and the adults with autism and their families. They need community supports and services. We need to make sure that we have enough. They have medical needs that we need to not ignore. They need educational behavioral services from really early on. And the research is really driving to show us who's at risk and where are we going with this. Genetics plays a huge role. We don't have enough research to look at how children are doing as they're growing up. We know this prevalence is rising, and we're not exactly sure why. So what are all those contributing factors? We do know that more children are now attending regular school. We know that their outcome is really affected by language and whether or not there's intellectual disability. So what we need to focus on really early on is that communication, is really making sure children are able to communicate their needs, communicate to learn, because language is really important as a predictor of success. And that many more adults are now employed in at least part-time work and are living in the community. So do we have the supports out there to support more and more children who have been diagnosed early and are moving through our school system? There's a wide range of functioning in an autism spectrum disorder. It is an urgent public health concern, and that's why agencies such as where I work, the CDC, are really focused on making sure, in my case, we're focusing on that early identification piece. There's other agencies looking, funds and USEDs to make sure that there are lots of programs and resources and education for people across the lifespan. Early identification and intervention is crucial to long-term outcomes. more research is needed to look at these causes and look at these risk factors, but we need to keep a lifetime perspective, and we need to understand autism from really early on, all the way through the lifespan to young adults and into adulthood. So I want to acknowledge my colleagues at the CDC for helping me sort of understand autism better, putting this talk together, but also teaching me all of the different parts that make this work. I think the families of the children and the children in my clinic really inform everything that I do. And it's the individual families and the successes and the challenges that we have that really make me keep wanting to look at how do we do what's best and what's right for children and adults in the community so that they can be successful, productive, included members of our community. And of course, as was mentioned before, I need to always, I think, publicly thank my family, because I couldn't be here doing this for you if I didn't have someone at home taking care of my children, so that I can hopefully impact the lives of families and children with autism in different places. So what's the plan for the rest of the day? You've met Shanna, and I think you're going to do an introduction in a little bit, but I just wanted to know that Dr. Shanna Kralovic is with me today, and what we are going to do is lead you through some breakout sessions that will help delve more into some of the details that I've talked about in this session. The morning sessions are going to focus on early identification, screening, and diagnosis, and the afternoon sessions are going to be on treatment and caring for children with autism. And you're going to be divided into two groups so that we can have a little more discussion and a little more back and forth. Because you've been sitting patiently for a long time listening to me, and I appreciate that. So I wanted to thank you for listening, and I thank you for being here. Thank you for taking a whole day out to really make the lives of children with autism better. Thank you.
My father used to tell me that the mind will only accept what the behind will endure. We did not have that problem here. That was great. Just a couple of housekeeping issues. We're going to take about a 10-minute break. We're running just a little bit behind schedule. We're going to pull the dividers. And Dr. Peacock's session is going to, this is the first time we focus, like we're focusing today, on direct caregivers. So Dr. Peacock is going to have the more advanced section, I guess is the best way to put it.
And so what we were thinking, because we were listening to what you all do, and some of it's going to be, I think, self-selection, right? We haven't put people in categories. So what we were thinking is, if you're in the medical field, if you're in psychology, if you're in allied health, or special ed, right? That we would put you all in one room, and then if you're a community member, if you're a family member, if you're here to learn more about autism, then we'll put you in another group. And really, we're going over the same things. We just may go into details a little differently. And then what will happen is, this morning I'm with the healthcare provider group, that group, and then in the afternoon I'm going to be with the community parent sort of group, and Shanna's going to switch with me. And so, does that make sense? Because I think that'll get us to sort of more half and half. Okay, so what did you all see as he not only responded to his name, what are the other things that you saw him doing? He pointed. He followed and turned to the person who was talking. All right, so I want to show you, I apologize for the interruptions. Now I want to show you a child at 18 months. His name's Evan. And we're going to talk about the differences that we're seeing in these two children.
You want to try to say the name to respond to that?
Evan.
See maybe if you can get him to respond to you now, you can use touch with his name like it rolls like a little thing.
Evan.
He likes the pickles, but he's just not going to use too much eye contact, but he does smile when you pickle him.
Evan.
Okay, so what did we see? I mean, clearly we're seeing something very different in those children, and this child is 6 months older as well. But what specifically did you see or not see in this second child? No, so let's go one at a time. So no eye contact? Non-responding to the name. What else? Didn't respond to touch, but we got some response to touch. And so, what else did we see? He turned away. Okay, so he didn't really want that interaction. And so, those are pretty stark differences in what we're seeing, but they're the types of things that we want Head Start providers to look for. We want to look for in pediatricians' offices. We want to look for in child care settings because we expect that every child would be responding to their name, certainly by 18 months and definitely by 12 months. So the other thing that we talked about was joint attention. And what I'd like to do is really sort of pull apart what joint attention looks like. And this video really gives us a good example of seeing how that happens.
You see, as he's walking and saying hi to the bear. Okay. That's it. No more. No more.
So watch it in slow motion now. You see the looking, pointing, and mom's pointing, and so the baby is following a point as well, and then looking back at the mom and references the boy. So it's going to speed up again, and we can watch it again.
You see, as he's walking and saying hi to the bear. Okay. That's it. No more. No more. Nothing.
So do you see how that child is sort of referencing back? So the child is always looking back at all of the different people that she's interacting with. She's using her finger to point, and she's using her eyes to communicate, and she's initiating communication as well as following that communication of that family. So that's a complicated thing to maybe look for all of those pieces. However, if you practice looking for those pieces, it will come more naturally to you. And joint attention is really one of the core things that children need in order to continue to develop. And so, because that's how they're learning. They're learning through that joint engagement and that joint attention. So we can find that if we're doing a well child visit with a child by getting a book out in the clinic office and sort of watching that interaction, either just like this, so with a mom showing the child something in a book, or the child showing the mom something in the book, or you could do it with a different object. In a child care setting, you've got more time, but again, you want to be looking for these different ways that the child is interacting and see that that's there. We would expect these types of things to be present very, very early on. I'm going to show you how to get to this video library at the end of the talk, just so that you can see that. The last video I'm going to show you that really looks at, actually I'm going to show you two more, because I'm going to show you one that shows play, at a really young age, and some of the things that we would be interested in looking for. So he's pretty focused on his task right now. And we expect that in a child who's 12 or 13 months old. So he's really trying to figure out how those cups come together. What did he say? He's saying he's communicating, right? He's saying, doesn't work. And now he's trying to get someone involved in this play. So even though he doesn't have words at this age, he's definitely trying to engage the other person in the room. And I think that that's what's important to understand, is that communication is happening way before those words come in. And so we're looking for the nonverbal communication. He's doing a very good job of getting his I think, dad to try to work with him. And he's getting more engaged with his dad as he's getting more interested in this play. What do other people, so a lot of you in the audience are much more experienced with child play than I am. So I'm usually in a clinic, and usually kids are scared when they're coming to see us in the pediatrician's office. So what other things would you say about play in this age group that we should be looking for? Nothing?
So you try to mimic. If you kind of
Mimic,
out,
right. Imitation. So there's a lot of imitation that's going on. Children learn by imitation, and so if they're not making eye contact, if they're not paying attention and jointly engaging, they're missing a lot of those cues for interaction and for imitation. He was trying to problem solve, so we're seeing, we're seeing persistence too, right? He didn't get frustrated and just say, I'm done with this. He kept trying to make that toy work, even though it wasn't doing exactly what he wanted to do. And when he couldn't figure out how to make it work the way he wanted to, he asked someone to help him. And so he understood that there was somebody else in the room that could help him solve the task that he was trying to solve. What else do we see? Anything else? I think it's a pretty good list. So I want to give people a chance if they have something. Okay.
Make a decision.
Barney is making a decision. Okay. So now I'm going to play you, this is a little longer video, but I want you to see the progression. Actually, let me stop it so I can talk. So this is going to show you a progression of sort of literacy through early childhood. And again, what I'm trying to point out with sort of this part of our session, and we're going to move pretty quickly onto screening and diagnosis, is that we all can become better observers. And the way you become better observers of child development is by practicing. And one way to do it is you can take, if you look in this Milestone Moments booklet, you can see that we've divided the milestones out into social, emotional, language and communication, cognition, which includes problem solving, thinking and learning, and then movement and physical development. And if you can look at a child at a specific age, at 2 months, at 4 months, at 6 months, whenever you might be seeing them, either in a well-child visit as a pediatrician or in a teaching setting, something like that, try to create an image in your mind of what a 4-year-old or a 2-year-old or whatever that is supposed to look like. And so you can create an image or have a picture in your mind, and right before, in this case, if you're going in to see them for a well child check, right before you go in, say, okay, I'm going to be seeing an 18-month-old. What should they be doing as far as language? What should they be doing as far as motor skills? What should they be doing as far as problem solving? And sort of go through those different things right before you assess that child. And you'll be able to sort of build up your capacity and build up your ability to identify either warning signs and also typical child development at different ages. So let me show you this reading sequence, and then we're going to move on to screening.
There, very good. Okay, okay. Can you read it for me? Can you read the story? Read the story. Yeah.
So it's pointing to some pictures, it's interacting with the teacher, turning the book pages, looking at pictures.
Say Humpty Dumpty? Yes, what did Humpty Dumpty do? Is that on the wall? Is that on the wall? Yes.
So imitating.
He fell down. Did he fall down? I just fall. Yeah.
This child's around 24 to 30 months.
You are a squirrel. Squirrel.
So you can't hear too well, but he's starting to tell part of the story. So he's looking at the whole picture and then thinking about what he's going to tell you about. What? Much older. Remember, we had lots of those words over here. Starts with what's the first letter? So. Two more words. What's the first part? The TH. And now I'm going to move. This one's pretty long. Yeah. Right. So what a lot of fish there are. Good job. And now we've got a fluent, much more fluent readers.